Hello students, in today's video we are going to discuss pharmacology of antidiabetics or antidiabetic drugs. Antidiabetic drugs are also known as hypoglycemic drugs as these drugs reduce concentration of glucose in the blood and are used in the treatment of type 2 diabetes mellitus. Now before discussing pharmacology of antidiabetic drugs, let's quickly understand diabetes mellitus. Diabetes mellitus is of two types, type 1 diabetes mellitus and type 2 diabetes mellitus. Now insulin is absent in type 1 diabetes mellitus, but type 2 diabetes mellitus is caused due to insulin resistance, that is reduced functioning of insulin, but as the disease progresses, there develops gradual deficiency of insulin. Now let's understand why insulin is important. Now, insulin is essential for the transportation of glucose from the blood to the body cells. So, this reduces concentration of glucose in the blood. So, insulin resistance and or insulin deficiency causes reduced uptake of glucose by the adipose tissues, reduced uptake of glucose by the skeletal muscles, and increased breakdown of glycogen stored in the liver to release glucose. So all these actions increase concentration of glucose in the blood known as hyperglycemia. And hyperglycemia for long period of time causes diabetes mellitus. Now type 1 diabetes mellitus is treated by insulin therapy as insulin is absent in type 1 diabetes mellitus. But type 2 diabetes mellitus is treated by anti-diabetic drugs. So let's now understand classification of anti-diabetic drugs. This is a classification of anti-diabetic drugs. All these drugs are administered orally except GLP-1 receptor agonist and amylin analog. Now both these two classes of drugs are administered by subcutaneous injection. Now first category of anti-diabetic drugs stimulate pancreatic beta cells to increase insulin secretion. So these drugs enhance secretion of insulin. These are further classified as ATP sensitive potassium channel blockers, GLP-1 receptor agonist and DPP-4 inhibitors. Now sulfonylureas and maglitinide analogs are the class of drugs that block ATP sensitive potassium channels of pancreatic beta cells to increase the secretion of insulin. Now talking about sulfonylureas, second generation sulfonylureas are preferred over the first generation sulfonylureas. Second generation sulfonylureas are long acting drugs and can cause serious hypoglycemia, and blood glucose levels can fall to below normal levels. Now hypoglycemia results in tiredness, fainting, mental confusion. As the brain requires glucose, very low blood glucose can cause diabetic coma. Maglitinide analogs also block ATP sensitive potassium channels, but these drugs act on a site different than sulfonylureas. Now these drugs also increase insulin secretion. Now unlike sulfonylureas, these drugs have a short duration of action and the risk of hypoglycemia is lesser than sulfonylureas. Another class of drugs that increase insulin secretion are GLP-1 receptor agonist and DPP-4 inhibitors. Now these drugs increase insulin secretion when concentration of glucose is high in the blood. Thus these drugs do not produce the risk of hypoglycemia. After the first class of drugs that increase insulin secretion, now second category of anti-diabetic drugs are those drugs that overcome, that is reduce or control insulin resistance. Now these drugs increase action or these drugs increase effectiveness of insulin, and thus these drugs improve insulin sensitivity. These include biguanides and thiazolidinediones. Now these drugs do not cause hypoglycemia. Now, metformin is the only biguanide drug. It reduces insulin resistance by activating AMPK, that is by activating AMP-dependent protein kinase. Now, very important to note, metformin is the drug of choice in the treatment of all types of type 2 diabetes mellitus. Now, pioglitazone. Pioglitazone is a thiazolidinedione. It acts on nuclear receptors, that is the receptor present on the nucleus. It is a selective agonist of nuclear peroxisome proliferator activated receptor gamma, in short PPAR gamma. And pioglitazone is used as a second or third line therapy in the management of type 2 diabetes mellitus. Now, the third category of drugs are the miscellaneous drugs. Now, alpha-glucosidase inhibitors are the drugs that inhibit alpha-glucosidase enzyme. Now, alpha-glucosidase enzyme digest or break carbohydrates to glucose. Thus, inhibition of this enzyme reduces production and absorption of glucose in the blood. Now, acarbose is the most common and widely used alpha-glucosidase inhibitor. Now, next class of drugs is the amylin analog. Now, pramlintide is a synthetic amylin analog. It produces action similar to naturally produced amylin hormone from pancreatic beta cells. It is administered subcutaneously along with mealtime insulin and improves glycemic control in type 1 and also in advanced poorly controlled type 2 diabetes mellitus. Another class is dopamine D2 agonist. The drug is bromocriptine. Bromocriptine can be used as a supplement with other antidiabetic drugs. It also reduces insulin resistance. Another class is the sodium glucose cotransport 2, in short SGL2 inhibitors. Now, these drugs inhibit sodium glucose cotransport 2 in the proximal convoluted tubules of the nephron of kidney, thereby inhibiting reabsorption of glucose in the blood. And this reduces concentration of glucose in the blood. So, this is the classification of anti-diabetic drugs. As discussed, metformin is the drug of choice in all cases of type 2 diabetes mellitus. Now, use of other drugs depends upon the characteristic features of the patient and severity of type 2 diabetes mellitus. So, let's discuss pharmacology in brief of each class of these drugs. Let's first discuss pharmacology of sulfonylureas. Now, tolbutamide is the first generation sulfonylurea. Second generation sulfonylureas include glibenclamide, glipizide, glyclazide, glimepiride. Now, second generation sulfonylureas are more potent, clinically superior, with longer duration of action. Now, look at this figure of pancreatic beta cell explaining mechanism of action of sulfonylureas. Now, sulfonylureas bind to sulfonylurea receptors, that is SUR1, located on ATP sensitive potassium channels. This closes ATP sensitive potassium channels and prevent movement of potassium ions outside the cell. So, potassium accumulates in the cell and this leads to cell depolarization. Further, it causes influx of calcium, exocytosis and release of insulin. Now, increased secretion of insulin increases transportation of glucose from the blood to the body cells, thereby reducing concentration of glucose in the blood. Now, in addition to this, these drugs also inhibit the process of gluconeogenesis in the liver. So, this inhibits synthesis of glucose in the liver and thereby reduce release of glucose from the liver. and this reduces levels of glucose in the blood of type 2 diabetes mellitus patients. Then indications, sulfonylureas are oral hypoglycemic drugs that are used in the treatment of type 2 diabetes mellitus. Now, adverse effects. Now, sulfonylureas increase insulin secretion regardless of blood glucose levels. That is, they increase insulin secretion even if glucose is less in the blood. So, sulfonylureas can cause glucose levels to fall below normal, producing hypoglycemia, which can be severe. Now, increase in the insulin secretion can also cause weight gain. Now, in addition to this, sulfonylureas interact with a number of other drugs. So, this is in brief on pharmacology of sulfonylureas. Now, the next class of oral anti-diabetic drugs that increase insulin secretion are maglitinide analogs. Now, this include drugs repaglinide and netiglinide. Now, these drugs also increase insulin secretion. Now, maglitinide analogs are structurally different from sulfonylureas, but they act similar to sulfonylureas. So, these drugs also block ATP-sensitive potassium channels on pancreatic beta cells, but they bind to a site different than sulfonylureas. Now, these drugs also increase insulin secretion regardless of the blood glucose levels. So, situations like, for example, skipping meals after taking the drug can cause hypoglycemia. Now, unlike sulfonylureas, these drugs have a rapid onset and short duration of action. Now, because of their rapid onset and their short duration of action, these drugs are very useful in controlling postprandial, that is after meal, rise in the blood glucose levels. So, these drugs are used in the treatment of type 2 diabetes mellitus along with other anti-diabetic drugs to control postprandial rise in blood glucose. Now, like sulfonylureas, these drugs also increase insulin secretion and can produce hypoglycemia and weight gain. However, the risk of hypoglycemia is lower compared to sulfonylureas. So, this is in brief pharmacology of maglitinide analogs. Now, the next class of drugs that increase insulin secretion are glucagon-like peptide 1, in short GLP-1 receptor agonist, and dipeptidyl peptidase 4, in short DPP-4 inhibitors. Now, let's first understand what is GLP-1 and DPP-4. Now, carbohydrates in the food release glucose. Glucose stimulates gut or intestine to release GLP-1. GLP-1 is an incretin, an intestinal hormone that binds to GLP-1 receptors and produces these four main effects that improve glycemic control. Now, GLP-1 is rapidly broken down to inactive metabolites by the enzyme dipeptidyl peptidase 4, in short DPP-4. Now, GLP-1 receptor agonist, namely exenatide, liraglutide, are administered subcutaneously. Now, these drugs are resistant to the action of DPP-4. That means these drugs are not broken down by DPP-4. These drugs stimulate GLP-1 receptors to produce the effects as produced by the natural GLP-1. Now, DPP-4 inhibitors, namely sitagliptin, vildagliptin, sexagliptin, allogliptin, linagliptin, inhibit DPP-4, thereby preventing the breakdown of this naturally produced GLP-1 and enhance or increase its action and efficacy. So, GLP-1 receptor agonists produce actions as that of naturally produced GLP-1, while DPP-4 inhibitors prevent breakdown of GLP-1 and enhance or increase its efficacy. So, GLP-1 binds to GLP-1 receptors. Now, let's understand the actions of GLP-1 receptor agonist and DPP-4 inhibitors. So, GLP-1 binds to GLP-1 receptors on the pancreas and increase secretion of insulin from pancreatic beta cells, thereby increasing transportation of glucose from the blood to the body cells, which reduces concentration of glucose in the blood. Now, very important, GLP-1 receptor agonist and DPP-4 inhibitors cause increased insulin secretion only if concentration of glucose is high in the blood, that is postprandially after eating food. So, these drugs do not cause hypoglycemia. Now, these drugs also reduce secretion of glucagon from pancreatic alpha cells. This prevents breakdown of glycogen stored in the liver to glucose. So, release of glucose from the liver reduces, which also reduces glucose in the blood. So, both these actions of these drugs are responsible for reducing levels of glucose in the blood. Now, in addition to this, these drugs also reduce gastric emptying that causes sluggish or slow movement of food from the stomach to intestine. And these drugs also promote satiety, that is the feeling of fullness after consuming food. So, these two factors reduce consumption of food, and thus in addition to reducing blood glucose in the that is the levels of glucose in the blood, these drugs also modestly promote the weight loss. So, this is how GLP-1 receptor agonist and DPP-4 inhibitors reduce blood glucose levels, improve glycemic control and promote weight loss. Now, indication, these drugs are used as add-on therapy and are thus supplemented to other anti-diabetic drugs for the treatment of poorly controlled type 2 diabetes mellitus. Now, adverse effects of GLP-1 receptor agonist. These drugs produce nausea, vomiting and can cause increased risk of pancreatitis. Then DPP-4 inhibitors, they produce adverse effects like diarrhea, constipation, then nasopharyngitis, respiratory and urinary infections, and can cause increased risk of pancreatitis. So, this is in brief pharmacology of GLP-1 receptor agonist and DPP-4 inhibitors. Now, after the first category of drugs that increase insulin secretion, second category of drugs are the drugs that increase insulin sensitivity, thereby improving insulin action and reduce insulin resistance. Now, in this category of drugs that enhance insulin sensitivity, the first class of drugs is the biguanides. Now, biguanides include only one drug, that is the metformin. So, metformin reduces insulin resistance and increase insulin sensitivity. Now, very important, metformin is the first choice oral anti-diabetic drug for the management of type 2 diabetes mellitus. Now, let's first discuss mechanism of action of metformin. Now, metformin activates AMP-dependent protein kinase, in short AMPK. Now, AMPK activation by metformin increases insulin sensitivity. Now, metformin inhibits mitochondrial respiratory chain of a cell. Now, this reduces synthesis of ATP, thereby increasing AMP-ATP ratio, and this causes activation of AMPK. Now, AMPK acts on the cells of liver, adipose tissue and the skeletal muscles. Now, in liver, AMPK inhibits the process of gluconeogenesis, and therefore substrates like lactate, amino acids, glycerol, etc. are not converted to glucose. So, this reduces synthesis of glucose in the liver, and this further reduces levels of glucose in the blood of type 2 diabetes mellitus patient. Now, another very important thing, inhibition of the process of gluconeogenesis can cause accumulation of lactate in the blood, which reduces pH of blood and can cause lactic acidosis. Now, lactic acidosis is a rare but a serious adverse effect of metformin. Now, in addition to this, AMPK activation also increases uptake of glucose by the adipose tissue and increases uptake of glucose by the skeletal muscles, thereby reducing concentration of glucose in the blood. Thus, metformin, by activating AMP-dependent protein kinase, increases insulin sensitivity and decreases basal as well as postprandial, that is after meal, rise in the blood glucose levels. And it is used for the treatment of type 2 diabetes mellitus. Now, adverse effects. Now, gastrointestinal adverse effects are the main adverse effects of metformin, and these include diarrhea, nausea, vomiting, abdominal pain, anorexia, that is loss of appetite, bloating, etc. Now, these gastrointestinal adverse effects can cause weight loss in the patient. Then another adverse effect is lactic acidosis, which is rare but which can be serious. Now, long-term use of metformin can cause deficiency of vitamin B12. So, this is in brief pharmacology of metformin. Now, the next class of oral antidiabetic drugs that increase insulin sensitivity and reduce insulin resistance is the thiazolidinediones. Now, drug pioglitazone belongs to this class. Now, let's discuss mechanism of action of pioglitazone. Pioglitazone is a selective agonist of receptor present on the nucleus. So, pioglitazone is a selective agonist of nuclear peroxisome proliferator activated receptor gamma, that is PPAR gamma. So, pioglitazone binds to and activate PPAR gamma. This causes increased transcription of genes and thus increased synthesis of proteins that improve glucose and fatty acid metabolism, thereby increasing the insulin sensitivity. So, pioglitazone causes increased synthesis of proteins like GLUT4, that is the glucose transporter 4, then increased synthesis of protein, that is lipoprotein lipase, and increased synthesis of protein, that is FATP, fatty acid transporter protein. So, look at this cell. This is a fat cell or adipocyte. Now, GLUT4, glucose transporter 4, are the proteins responsible for increased uptake of glucose from the blood by the adipose tissues and also by skeletal muscles, thereby reducing blood glucose levels. Now, in fat cells, glucose is converted to glycerol. Now, lipoprotein lipase breaks triglycerides in the blood to fatty acids. Now, these fatty acids are transported inside the fat cells by fatty acid transporter proteins or FATP. Now, inside the fat cells, these fatty acids combine with glycerol to produce triglycerides which are stored. So, increased transcription and synthesis of GLUT4 increase glucose uptake and improve glucose metabolism, while increased transcription and synthesis of lipoprotein lipase and FATP increase synthesis and storage of triglycerides in the fat cells, that is improve fatty acid metabolism. So increased synthesis of these proteins improve insulin sensitivity, thereby improving the glycemic control. Now, in addition to this, pioglitazone also inhibits hepatic gluconeogenesis, thereby reducing synthesis of glucose in the liver and reducing blood glucose levels. Now, pioglitazone also increases level of high density lipids, that is HDL, that is good cholesterol, by acting on PPAR alpha receptors. Now, indications of pioglitazone. Pioglitazone is used as a second or third line therapy in the management of type 2 diabetes mellitus. Then adverse effects. Now, pioglitazone increases reabsorption of sodium in the collecting tubules of kidneys, thereby causing increased reabsorption of water too. So, this increases blood volume and cause expansion of plasma volume. Now, expansion of plasma volume can cause edema or swelling. Now, increase in the plasma volume and increased synthesis of triglycerides in the adipose tissues can cause increase in the weight. Pioglitazone can also cause hepatotoxicity, and since it causes edema, it can increase the risk of congestive heart failure. So, this is in brief on pharmacology of pioglitazone. After discussing drugs that increase insulin secretion and drugs that increase insulin sensitivity, let's study third category of miscellaneous drugs. Now, first class of drugs administered orally in this category are alpha glucosidase inhibitors. Now, this class includes drugs namely acarbose, miglitol, voglibos. Now, acarbose is the most widely and most commonly used alpha glucosidase inhibitors. Now, let's first understand mechanism of action of acarbose. Now, as the name suggests, alpha glucosidase inhibitors inhibit the enzyme alpha glucosidase. Now, look at this figure. This is a zoomed section of small intestine. This is the lumen of intestine. Now, partially digested food from the stomach pass into the small intestine. This is the intestinal wall, which is made up of epithelial cells called as enterocytes. Now, alpha glucosidase enzymes are located on the brush border of these enterocytes. Now, look at this schematic diagram. Now, carbohydrates like starch in the diet are polysaccharides made up of more than 10 sugar molecules. Now, these polysaccharides are broken down or are digested by enzyme alpha amylase to short polysaccharides made up of 3 to 10 sugar molecules and are called as oligosaccharides. Now, look here. This is an oligosaccharide which is made up of 4 sugar molecules. Now, enzyme alpha glucosidase breaks this oligosaccharide to release a glucose molecule. This glucose is transported in the enterocyte and then it is absorbed in the blood. So, release of glucose molecules from polysaccharides and from oligosaccharides and their absorption in the blood is responsible for postprandial, that is after meals, rise in the blood glucose levels. Now, look here. This is acarbose. This is alpha glucosidase inhibitor. So, acarbose blocks the enzyme alpha glucosidase. Now, this prevents breakdown of this oligosaccharide, and thus glucose is neither released nor it is absorbed in the blood. So, this prevents rise in the concentration of glucose in the blood after eating food. So, acarbose is a competitive reversible inhibitor of enzyme alpha glucosidase. It also inhibits enzyme alpha amylase. Therefore, it prevents the release of glucose and absorption of glucose in the blood, thereby preventing rise in the blood glucose levels. So, acarbose prevents postprandial, that is after consumption of meal, rise in the blood glucose levels. Now, indications of acarbose. Acarbose is administered orally as it prevents absorption of glucose in the blood, as it prevents rise in the blood glucose levels. It is termed as a mild anti-hyperglycemic. It is used as a supplementary drug. That means it is used as an additional drug. It is used along with other anti-diabetic drugs in the management of type 2 diabetes mellitus. Then adverse effects. Now, as acarbose prevents digestion of carbohydrates. Now, undigested carbohydrates in the colon are acted upon by the colonic bacteria. So, colonic bacteria cause fermentation of undigested carbohydrates, which causes excessive generation of gas. And this excessive generation of gas is responsible for adverse effects like flatulence, bloating, abdominal pain and diarrhea. Now, in addition to this, acarbose can cause increase in liver transaminases. Therefore, monitoring of liver function is essential. So, this is in brief on pharmacology of acarbose. Now, the next class of orally administered miscellaneous drugs is sodium glucose cotransport 2, that is SGLT2 inhibitors. Now, these drugs in this class are dapagliflozin, then empagliflozin, canagliflozin, ertugliflozin. Now, let's first discuss mechanism of action of these drugs. Now, these drugs act on the proximal convoluted tubule of the nephron of the kidney. So, look at this figure. This is the structure of nephron, and this part of the nephron is called as the proximal convoluted tubule. Now, blood in the glomerulus is filtered and the filtrate passes into the lumen of the nephron. Now, these are the glucose molecules. Now, around 90% of the glucose in the filtrate is transported to these epithelial cells, and from these epithelial cells, that glucose is absorbed in the blood of these peritubular capillaries. So, this is the zoomed view of proximal convoluted tubule. Now, sodium and glucose in the filtrate is transported to the epithelial cells of proximal convoluted tubule by SGLT2. Now, further GLUT2, that is a glucose transporter 2, transports this glucose to the blood of peritubular capillaries. So, this is how glucose in the filtrate is reabsorbed in the blood of peritubular capillaries. Now, SGLT2 inhibitors inhibit sodium glucose cotransport 2, thereby inhibiting reabsorption of this glucose from the filtrate into the blood. So, this glucose is not absorbed in the blood. On the contrary, this glucose is excreted in the urine along with a lot of fluids. So, reduced reabsorption of this glucose reduces levels of glucose in the blood, and this also increases the excretion of glucose in the urine, which is termed as glucoseuria. Now, because of the increased urination, the frequency of urination increased, which is termed as polyuria. Now, indications of SGLT2 inhibitors. These drugs are administered orally, and these drugs are used as an adjuvant therapy. That means these drugs are used along with other anti-diabetic drugs for the treatment of type 2 diabetes mellitus. Then adverse effects of these drugs. Now, glucoseuria, that is increased excretion of glucose in the urine, predisposes to urinary and genital infections. Then excessive urination leads to diuresis, and diuresis leads to electrolyte imbalance, dehydration, then increased urinary frequency, that is polyuria. Now in addition to this, excessive urination reduces the volume of blood, which can cause hypotension. Now, in addition to this, SGLT2 inhibitors can also cause diabetic ketoacidosis. So, this is in brief on pharmacology of sodium glucose cotransport 2 inhibitors. Now, the last class of miscellaneous drugs we are going to study in this video is the amylin analog. Pramlintide is a drug that belongs to this class. Now, pramlintide is a synthetic amylin analog and it is administered by subcutaneous injection. Now, very important to understand that amylin is a hormone which is released by pancreatic beta cells along with insulin. Now, insulin and amylin both are absent in type 1 diabetes mellitus. Now, type 2 diabetes mellitus is caused due to insulin resistance. But as the disease progresses, there occurs a gradual deficiency of amylin and insulin in advanced, poorly controlled type 2 diabetes mellitus. So, let's first understand the mechanism of action of pramlintide. Now, pramlintide's mechanism of action is similar to natural amylin's action. Now, pramlintide acts on the pancreas and reduce secretion of glucagon. Now, reduced secretion of glucagon reduces breakdown of glycogen stored in the liver to glucose. So, this reduces release of glucose from the liver, which in turn reduces levels of glucose in the blood. Now, in addition to this, pramlintide acts on the brain. It promotes satiety, that is the feeling of fullness, and also delays gastric emptying, that slows down the movement of food content from the stomach to the intestine. Now, both these effects suppress appetite, reduce intake of food and carbohydrate, that in turn reduce glucose levels and promote weight loss. Thus, pramlintide, by acting on the pancreas and the brain, reduce glucose in the blood and also promote weight loss. Now, indication: pramlintide is used as an adjuvant or as an additional drug with mealtime insulin injection to suppress postprandial, that is after meals, rise in the blood glucose levels in type 1 and also in advanced, poorly controlled type 2 diabetes mellitus. Then adverse effects: as pramlintide slows gastric emptying, it can cause nausea, vomiting, then it can cause anorexia, that is loss of appetite, and this drug can also cause hypoglycemia. So this is in brief on pharmacology of pramlintide. So we have discussed in brief pharmacology of almost all anti-diabetic drugs. Now, these anti-diabetic drugs are not recommended to be used during pregnancy or lactation, and none of these drugs except pramlintide should be used in the treatment of type 1 diabetes mellitus. Now, as already discussed, metformin is the first choice drug for the treatment of all types of type 2 diabetes mellitus. Now, use of all the other drugs as alternatives or second line treatment option depends upon the characteristic of each patient and the severity of type 2 diabetes mellitus. Please note, information provided in this video is meant for academic informative purpose. For the use of these drugs or for the treatment of diabetes mellitus, consult your physician. If you find the video useful, kindly like, subscribe or share this video. Thanks for watching this video.